Hello everyone, welcome to sqadia.com, and in our third section of the lecture topic Urogynaecology, we will talk about the clinical assessment and examination of the patient. So in this we will talk about what are the investigations, how we can assess and examine the patient with the incontinence. So in clinical assessment of incontinence, usually history is very important. And in the history, we should ask about the incontinence, what are the different factors that leads to the incontinence, how often it occurs, and all these questions should be asked. So incontinence on physical examination or physical activity, incontinence with mixed symptoms, and if there is incontinence with urgency and frequency. So these all should be asked. Then the clinical assessment, and in the clinical assessment, what's the general assessment of the patient? Then we should ask about the urinary diary, how often they need to urinate, if it is associated with any pain, discomfort, if they have any burning sensation, if they have any difficulty on urination. Then assess about the quality of life and desire for the treatment. And then in the physical examination, we examine, it should be abdominal, rectal, sacral, neurological, and estrogen status of the patient. If they are postmenopausal, if there are atrophic changes that can lead to stress incontinence, or whether they have incontinence associated with coughing, sneezing, and laughing, if they have incontinence with physical activity, what grade of physical activity leads to incontinence, whether it occurs on rest or on with the change of posture, position. All these questions should be asked. If usually if they have in the history, we should also ask the patient if they have associated pain with the process of urination, if there is any hematuria or blood coming with the urination, if they have any history of infection, if they have any radiation history, if they had any history of surgery, all that should be asked. Then the treatment for the patient, usually medical treatment or surgery is recommended, and then some exercises, bladder retraining exercises, and then pelvic floor muscle training exercises are recommended. And if the therapy and medical treatment is failed, usually the reconstructive surgery or surgical procedures are performed. So clinical assessment of incontinence should be depend on the history taking, and then physical examination of the patient, and then the treatment, and if the medical treatment fail, or if the muscle training or pelvic training exercises fail, then the surgery should be performed. The local examination, sometimes usually in the pelvic relaxation, usually some degree of cystocele or cystourethral is usually evident. In the cystocele, here if you see, cystocele is the bulging of the here, cervix, cystocele. Here, if you see in this diagram, there is bulging of the cervix, opening of the cervix. In the rectocele, there is bulging of the rectum here. And then in enterocele, there is bulging of the intestine. Then in the urethrocoele, bulging of the urethra. And in the uterine prolapse, there is movement or bulging of the uterus down into the vagina. So these are the different type of the bulging that leads to the incontinence. Cystocele in the cervix, in the rectum, bulging of the rectum. Entero is for intestine, bulging of the intestine. Urethro for the urethra here, and then uterine prolapse. So in the stress test, there is increased abdominal pressure is increased due to some physical activity, and then it is checked if that increase in the abdominal pressure can lead to the leakage of the urine. So in the Q-tip test, this is another test done to find out if there is any change in the position of the urethra. So in the normal, if the Q-tip is inserted in the normal resting position, this is the angle in which the Q-tip is inserted. That should be straight like this. And then with the Valsalva maneuver, the angle should be less than 30 degrees in the normal Q-tip test. Here, Valsalva maneuver is the forced exhalation with the closed mouth and nose, and when the person exhale, the pressure, this pressure should be or the angle of the movement of the urethra should be less than 30 degrees. If there is stress incontinence with the Valsalva maneuver, this angle is more than 30 degrees. Here, the Q-tip is elevated more than 30 degrees. So that's the Q-tip test to find out the stress incontinence. In the normal here, that's the normal position, little elevated. With stress incontinence, the angle is moved down little. The Q-tip is going like this, and then with the Valsalva maneuver, the angle becomes more than 30 degrees with stress incontinence. These are some investigations done to diagnose stress incontinence. The clinical stress test. If the person has stress incontinence, the clinical stress test in which the pressure on the abdomen is increased, that is reflected, leads to increased pressure on the urinary bladder and leads to the urination. So that clinical stress test is the positive in stress incontinence. Pad test is also positive in stress incontinence, in which the pad is put, and then patient is they drink lot of fluid, and then the pad is weighed before and then after, and if the usually the weight of the pad is increased due to the urination. So pad test is also positive. Midstream urine analysis is usually normal in stress incontinence. Usually the cystometry is also, there is a lowering of the urethral closure pressure in the cystometry. So this is normal here. So pressure is measured in the cystometry, and then usually the urethral closure pressure is lower. Leak point pressure test is positive. Cystourethhroscopy, usually no finding on cystourethhroscopy. Then Vediocystourethrography, there is bladder neck funneling. And then on transvaginal endosonography, there is altered anatomical relationship. So these are some special investigations done for diagnosis of stress incontinence. Midstream urine examination is done for culture and sensitivity, and if hematuria, if there is blood in the urine, then further testing should be done to find out if there are any malignant cell present. And then we also do cystourethhroscopy and IVU or intravenous urography. So all these tests should be done if there is hematuria or blood in the urine, and midstream urine specimen is obtained to you give a bottle to the patient, label bottle, and then ask the patient label container to discard the first half of the urine, collect the midstream, and then discard the last half. And this urine is usually collected for culture and sensitivity test. In the pad test, usually it's usually done for about 60 minutes. And how it is performed: apply pad with known weight. So usually weigh the pad before applying. And then patient usually drinks about 500 ml of salt-free liquid water and then sit and rest. Then in 30 minutes and to usually walk around and take some stairs. And then about 45 minutes they should sit, stand for 10 times, cough for 10 times, run for 1 minute, pick up some things from the floor and wash hands for 1 minute. And then at about 60-minute time, take the pad off and then weigh the pad and patient void and then measure the volume, how much they urinate. So that's the pad test. Give the pad to the patient before putting it, weigh the pad, then do different procedures, ask the patient to walk and then to cough and then to run, sit, stand. All these steps should be done, and then the pad should be weighed after 60 minutes. Residual urine is the urine that's left inside the bladder after the normal process of micturition. So this is the residual urine. Enlarged prostate in males is one of the very common reason for the residual urine when there is inability to empty the bladder fully and there is some urine left behind. So bladder is thickened and there is residual urine, and enlarged prostate in males is the common cause of the residual urine. Then urodynamic study. Urodynamic study is performed to find out the pressure in the bladder and in the urethra. Here, if you see, the transducers are abdominal pressure transducers here. This is inserted into the vagina. And then there is bladder pressure transducer inserted into the urinary bladder. And then abdominal pressure transducer is inserted into the vagina, and then there is recording on the monitor that gives you different pressure readings. One is urethral pressure, how much is it increased, total bladder pressure, intrinsic bladder pressure. Intrinsic bladder pressure is obtained by total bladder pressure minus the abdominal pressure. This is the abdominal pressure and then the saline flow when it is inserted. So these are all the readings obtained to find out the pressure in the stress incontinence. It gives us urethral pressure, it gives us total bladder pressure, which is obtained by the subtracting abdominal pressure from the total bladder pressure. Then we have Uroflowmetry, in which the urine, it's measured, in which the patient micturate or urinate in a funnel shaped in equipment, and then here it is measured how much the urine is, what was the frequency and volume of the urine. So here, if you see, that's how it is measured, how much time, flow time, and the maximum amount of the urine voided, and maximum flow rate, or what was the flow rate of the urine. So Uroflowmetry. Then we have cystometry. Is the abnormal cystometry is usually when the urine leaks on coughing. Usually there is no rise in detrusal pressure, and there is detrusal contraction during filling phase or overactive bladder. So here, if you see, the water is inserted due to the catheter. There is filling catheter, and then the other transducer which measure the bladder pressure, and then vaginal pressure catheter. So here, filling catheter, then we have bladder pressure catheter. Two catheters are in the urinary bladder. Then we have vaginal pressure catheter. All these record the pressures in different organs. Cystometry. There is urine leak. If there is abnormal cystometry, usually the urine leaks on coughing, and in stress incontinence there is detrusal pressure is not increased. It's just the pressure on the wall of the bladder, or on the pressure on the bladder due to increase in the abdominal pressure. So here, when the fluid is inserted and the pressure is increased, this can lead to the incontinence. Leak point pressure test. Leak point pressure test is done to find out what is the leaking point, or at what pressure the leaking of the urine starts. So what is the pressure, vesicourethral pressure, when the leaking of the urine starts? So in this, the bladder is filled with 200 ml to increase the intravesical pressure, and then the Valsalva maneuver, intra-abdominal pressure is increased by exhaling with the closed nose and closed mouth, and then we record the pressure at which the leaking begins. That's the leak point pressure test. So at what point or at what pressure the leaking starts. Then cystoscopy and urethroscopy. In this, the here cystoscope is inserted, and then we have again cystoscope, urethroscope here, is inserted to find out if there is these procedures are done to find out if there is any hematuria, if there is any suspected neoplasm, if there is any fistula, if there is any cystitis. All these are the indications to perform cystoscopy and urethroscopy, in which directly inside bladder we can examine if there are any abnormalities or any different changes in the bladder and the urethra. Then we have Vediocystourethrography, is the recording of the bladder and the urethra. And then here, if you see, this is the bladder, the contrast medium which is inserted or injected to take the picture. You see there is backing in the ureter here. There is backing of the fluid dye in the ureter. And here you can see the dilation of the kidneys. So that suggests there is some problem in the outflow of the urine, because there is backflow of the urine or the backflow of the dye in the ureter, and there is dilation of the kidneys leading to backing of the dye or the contrast medium into the ureter or the kidneys. So that was all about the section 3. Thank you for watching sqadia.com.